Welcome to our comprehensive guide on the pharmacotherapy of bipolar disorder. In this video, we'll explore the core concepts, treatment strategies, and clinical considerations for managing this complex psychiatric condition. Bipolar disorder, also known as manic depression, is characterized by dramatic shifts in mood, energy, and behavior. These fluctuations can be severe and life-threatening, requiring a nuanced approach to care. Our journey begins with understanding what defines bipolar disorder, its impact on individuals, and why effective treatment is so crucial. Let's set the stage for a deeper dive into the world of bipolar disorder management. Before we dive into the details, let's outline our learning objectives. By the end of this video, you'll be able to explain the pathophysiologic mechanisms underlying bipolar disorder, recognize the symptoms of manic episodes, list desired therapeutic outcomes, recommend drug therapies for both mania and depressive episodes, and understand the importance of monitoring for adverse effects. These objectives will guide our exploration and ensure you gain practical, actionable knowledge for clinical practice. According to the DSM-5, bipolar disorder is defined by the occurrence of manic or hypomanic episodes. It's a cyclical mood disorder where episodes of major depression alternate with periods of mania or hypomania. Unlike recurrent major depression, bipolar disorder always involves at least one episode of elevated mood. This lifelong illness can be unpredictable with varying courses and severities, making both pharmacologic and non-pharmacologic treatments essential for mood stabilization. Bipolar disorder is not just a series of mood swings, it's a lifelong condition that requires ongoing management. Unlike other mood disorders, the presence of manic or hypomanic episodes sets bipolar disorder apart. Both medication and lifestyle interventions play critical roles in achieving and maintaining mood stability. Understanding the chronic nature of this illness helps clinicians and patients set realistic expectations for treatment and recovery. Globally, bipolar disorder affects about 46 million people, with a lifetime prevalence of 4.4%. Bipolar I and II types are more common in women, while subthreshold forms are more prevalent in men. The disorder has a strong familial component, with first-degree relatives facing an 11-fold increased risk. These statistics highlight the widespread impact of bipolar disorder and the importance of early identification and intervention. Exact causes of bipolar disorder remain unclear, but it's believed to result from a complex interplay of genetic, developmental, and psychological factors. Multiple gene loci have been implicated in mood disorders, and neuroimaging studies show abnormalities in brain regions like the amygdala and prefrontal cortex. Environmental stressors, immune factors, and sleep disturbances can also influence the course of the illness, making it a multifaceted condition. Medical conditions can trigger manic episodes. Central nervous system disorders like brain tumors, strokes, and head injuries, as well as infections such as encephalitis and sepsis, are known contributors. Electrolyte imbalances, endocrine disorders, and hormonal changes, especially those related to menstruation or pregnancy, can also play a role. Recognizing these underlying causes is essential for accurate diagnosis and effective treatment planning. Several drugs can precipitate manic episodes in susceptible individuals. Alcohol intoxication, withdrawal from substances like antidepressants or benzodiazepines, and certain medications such as MAOIs, TCAs, and thyroid preparations are notable culprits. Understanding these triggers helps clinicians avoid iatrogenic mania and tailor treatment plans to minimize risk. Bipolar disorder is classified into several subtypes according to DSM-5. Bipolar I involves at least one manic or mixed episode, with or without major depression. Bipolar II is marked by major depressive episodes and at least one hypomanic episode, but no full manic episodes. Understanding these distinctions is key for accurate diagnosis and appropriate treatment selection. Cyclothymia is characterized by chronic mood fluctuations that don't meet the full criteria for mania or major depression, lasting at least 2 years in adults. Rapid cycling, on the other hand, involves 4 or more episodes of mania or depression within a single year. These subtypes present unique challenges and often require tailored treatment approaches. Bipolar disorder not otherwise specified, also known as bipolar spectrum, includes conditions with features of mania or hypomania that don't fit classic definitions. Mixed states where symptoms of depression and mania occur simultaneously can be particularly challenging to manage. These episodes may be short-lived but can last weeks or months, requiring careful assessment and intervention. Bipolar disorder progresses through distinct stages. Stage I is marked by euphoria, irritability, and increased activity, features of hypomania. Stage II involves dysphoria, unrest, and cognitive disorganization, corresponding to acute mania. Stage III can progress to psychotic states with features like hallucinations and panic. Recognizing these stages helps guide treatment intensity and monitoring. Major depressive episode in bipolar disorder requires at least 2 weeks of depressed mood or loss of interest, plus 5 or more symptoms such as appetite changes, sleep disturbances, psychomotor changes, impaired concentration, and suicidal thoughts. Accurate diagnosis is crucial, as treatment strategies differ significantly from unipolar depression. Mania is defined by at least 1 week of persistently elevated mood and energy, with 3 or more symptoms such as grandiosity, decreased need for sleep, pressured speech, racing thoughts, distractibility, risky behaviors, and poor judgment. Recognizing mania is essential for timely intervention and prevention of complications. Hypomania shares many features with mania but is less severe and lasts at least 4 days. Symptoms include elevated mood, increased energy, reduced need for sleep, pressured speech, and increased goal-directed activity. While hypomania may not cause significant impairment, it's a hallmark of bipolar II disorder and requires careful monitoring. primary goals of treatment are to resolve acute episodes of mania, hypomania, or depression, prevent future episodes, maintain healthy functioning, promote adherence, and minimize side effects. Achieving these outcomes requires a combination of medication, education, and lifestyle modifications tailored to each patient's needs. Treatment for bipolar disorder must be individualized, as clinical presentations and episode frequencies vary widely. Both non-pharmacologic and pharmacologic strategies are important. Educating patients and families about the disorder and treatment options is crucial for long-term adherence and stabilization. Choice of treatment depends on the type of episode, mania, hypomania, or depression. Once diagnosed, patients should remain on a mood stabilizer for life. During acute episodes, additional medications may be added and tapered as stability is achieved. For example, mania with psychotic features often requires both a mood stabilizer and an antipsychotic. Non-pharmacologic approaches are foundational in bipolar disorder management. Addressing nutrition, sleep, exercise, and stress reduction can significantly impact outcomes. Sleep deprivation and high stress can worsen mood episodes, while deficiencies in essential nutrients may also contribute to poor prognosis. These lifestyle factors should always be considered alongside medication. Psychological therapies equip individuals with self-management skills for mood regulation. Evidence-based approaches include cognitive behavioral therapy, interpersonal and social therapy, group psychoeducation, and family-focused therapy. These interventions complement medication and help patients develop resilience against mood swings. Pharmacotherapy is central to both acute and maintenance treatment of bipolar disorder. Key agents include mood stabilizers like lithium, valproate, carbamazepine, and lamotrigine, as well as first- and second-generation antipsychotics. Adjunctive agents such as antidepressants and benzodiazepines may also be used, depending on the clinical scenario. Managing hypomania starts with assessing secondary causes and discontinuing antidepressants or stimulants. Addressing substance abuse and encouraging healthy habits are essential. Mood stabilizers like lithium, valproate, carbamazepine, or SGAs are first line, with benzodiazepines as adjuncts. If there's no response, combination therapy may be considered. The approach to mania mirrors that of hypomania but often requires more intensive intervention. Initial therapy typically involves 2 drugs, lithium or valproate plus a benzodiazepine. If there's no response, a third agent is added. For refractory cases, ECT or clozapine may be considered, especially when psychosis is present. Acute bipolar depression management begins with ruling out secondary causes and optimizing lifestyle factors. Mood stabilizers like lithium or quetiapine are first line, with alternatives including lamotrigine, valproate, or a fluoxetine-olanzapine combination. The goal is to relieve depressive symptoms without triggering mania. Acute mania can have severe complications if left untreated. First-line treatments include lithium, valproate, and second-generation antipsychotics like aripiprazole, quetiapine, risperidone, and ziprasidone. Often, a combination of these agents is required for optimal symptom control. Valproate is initiated at 250 mg 3 times daily, with gradual increases to achieve serum levels between 45 and 125 mcg/ml. Alternatively, a loading regimen may be used for rapid effect. Baseline labs including CBC and liver function tests are essential before starting therapy, and ongoing monitoring is required to ensure safety. For women, a baseline pregnancy test is necessary before starting valproate due to teratogenic risks. Symptom improvement can be expected within about 5 days. It's important to review all concurrent medications to avoid interactions and ensure patient safety throughout therapy. Common side effects of valproate include gastrointestinal complaints, sedation, ataxia, tremor, hepatic enzyme elevations, and thrombocytopenia. Adjusting the dose, switching to extended-release formulations, or adding supportive medications can help manage these effects. Regular monitoring is essential to detect and address adverse reactions early. Lithium therapy requires careful baseline evaluation, as it can affect multiple organ systems. Baseline labs help distinguish lithium-related changes from other causes and identify contraindications or the need for dose adjustments. This proactive approach ensures safe and effective use of lithium in managing acute mania. For acute mania, lithium is started at 300 mg twice daily, aiming for serum levels between 0.5 and 1.2 mx/L. The onset of action is slow, taking 1 to 2 weeks for full effect. Adjunctive medications like benzodiazepines or SGAs may be used for rapid symptom control during this period.